Alright, so the first group we're going to talk about is going to be your amylins and your incretins. Amylin, again, gets released when insulin gets released. Pramlintide, or Simulin, is an amylin analog, and so it helps to reduce glucose absorption from the intestines, and it also signals satiety to the brain. This can be used with insulin in type 1 and type 2 diabetics at mealtime. And so you take your amylin when you're about to eat. It's going to cause that glucose to get absorbed a lot slower from the intestines. And you're also going to eat less because the brain is going to tell you that you're full, right? And then you get Byetta and Victoza, which are incretin mimics. Incretin is released when food enters the duodenum. And what it does is it causes the pancreas to release insulin before you get the blood sugar spike. So high blood sugar, that glucose entering via those GLUT4 receptors, right? Or GLUT2s, will cause insulin release. But you can also have incretins whenever food comes into the duodenum that stimulates the pancreas to go ahead and start priming the release of insulin. So hopefully that peak doesn't get so high. And so you can take this stuff before you eat to prime your insulin release so you have more insulin on board. This is really good for people who have type 2 diabetes. Most of these are going to be for people who have type 2 diabetes. This one's actually contraindicated for anybody who is taking insulin because it doubles the insulin and primes for insulin, and then you're going to crash, get hypoglycemic. Your secretagogues, this is used with people who have type 2 along with diet and exercise changes. So the secretagogues, if you look at these, you have your sulfonylureas that go ahead and close this calcium channel, or this potassium channel, which causes the opening of that calcium channel and causes the release of insulin. So these help you secrete insulin. There's the first gen ones like tolazamide, tolabutamide, still used, but less often than the second gens of lipizamide, glimepiride. And then we have our anti-hyperglycemic drugs. The previous drugs increase insulin, the response to insulin, the amount of insulin being released. These don't cause hypoglycemia because they don't increase the amount of insulin being released. Instead, they're going to do other stuff. So, miglydiol and arquebus affect glucose absorption. So these are glucose absorption inhibitors. They inhibit the enzymes that make glucose. So when you eat, most of us don't eat straight glucose, right? You eat stuff that has like fructose or dextrose or maltose or lactose or whatever it is, or complex carbs like starches that have to get broken down into glucose. And these inhibit those enzymes that break it down into glucose. So either they inhibit glycoside hydrolase or alpha amylase. Glycosate does glycoside. Precose does alpha amylase. Either way, you're going to have slower breakdown of glucose. It doesn't change the overall amount of glucose that gets into the blood, but it does affect that peak that comes up. So it's a much shallower peak because you have longer time to build up your insulin to combat the rising blood sugar. Some side effects you see is flatulence. Anytime you have extra sugar in your digestive system, the bacteria are going to feed on that, and they're going to give off gases, metabolic gases in response, which is going to cause you to fart. Can also cause diarrhea because you're increasing the osmotic pool into the intestine, and of course abdominal pain because diarrhea and flatulence, right? Metformin is a little bit different. This one decreases liver glucose production. So, and also a little bit in the intestinal absorption. So what metformin does is, in between meals, glucagon will do glycogenolysis. It'll be making glucagon. But metformin stops that from happening and also stops the intestine from absorbing more glucose, which can cause flatulence. Also, nausea and vomiting is not uncommon with metformin, and rarely you can get lactic acidosis, which is potentially deadly, kind of like ketoacidosis. We have more anti-hyperglycemic drugs, including our insulin sensitizers, Actos and Avandia. They activate the receptors inside the cell, and so they get it primed, right, for insulin. The first one of this group, troglitazone, was pulled off the market because it caused liver failure. Whoops. Nesia and sagaxagliptin. These are dipeptidase 4 inhibitors, so DPP4 inhibitors. One of your natural incretins, GLP-1, is metabolized by DDP4, and so if we stop that, then you're raising your natural incretin levels, which will go ahead and act like if you were taking an incretin mimetic, right? You can also pair this with metformin to have better control of blood sugar. Your Flozin drugs, like dapagliflozin for Farxiga, are sodium glucose cotransport 2 inhibitors, or SGLT2 inhibitors. Works a little bit different. So most of these have been working on the pancreas or the intestines, maybe sometimes the liver. These work on the kidneys, and they stop glucose from re-entering the blood. So if you remember, that superfiltrate from the glomerulus, like everything gets pulled out, right? And then glucose, a lot of it, like 99.9% of it, should get reabsorbed in the proximal convoluted tubules. That happens using these sodium glucose cotransporters. But you can inhibit that, and then the glucose is going to stay in the urine. So it doesn't cause you to have high blood glucose. You have normal blood glucose, but it pulls out and doesn't allow that glucose to get back in there. This can be taken with insulin. Side effect is, one, you're going to have dehydration because that sugar in the urine is going to keep it pretty osmotic. It's going to keep a lot of the water in the urine. It's going to pull out a lot of water every time you pee. But it can also cause urinary tract and yeast infections because of the extra sugar there. Typically what we see in diabetics is this cotransporter is just overwhelmed with the amount of sugar or glucose that gets pulled into the urine. So when you have really high blood glucose sugar or high blood glucose, all that can't get reabsorbed. A lot of it does, or else you wouldn't have high blood sugar, right? But you also lose a lot through the urine. Cool. So here's just kind of like a little summary thing. Insulin is going to work on its target tissues, muscle, liver, adipose. Your insulin sensitizers enhance your sensitivity to insulin, specifically liver, adipose, muscle. Metformin is going to decrease the amount of sugar you make from the liver. Pancreas insulin secretion can be increased using your secretagogues. or using your incretins, or indirectly using your DPP4 inhibitor, and then you can stop the breakdown of those oligosaccharides with your glucoside inhibitors or your amylase inhibitors. And that's it.